Okay, Assalamualaikum and good afternoon. Thank you to everyone around here as well as online. So today we will have Rachel to present on us on the simple topic, simple in theory, complex in practice on optimizing an ultrasound image. So without further ado, I'd like to welcome Rachel.
Good afternoon, everyone. Thank you, Dr. Amil, for the introduction. So my topic of presentation today will be optimizing an ultrasound image. But before I go into the core of the topic, I think it would be quite helpful if we could first understand how an ultrasound image is generated and then captured before we learn further how to attain an optimal ultrasound image. So just to start off the topic with some basic physics of ultrasound. So ultrasound waves are basically sound waves. And as the name suggests, it has a frequency which is very much higher than that of the audible human sound waves of 20 to 20 kilohertz. So they are basically pressure disturbances that travels through tissue medium in a series of compressions under high pressure and rarefactions under low pressure. And the speed at which they travel through the tissue medium may vary depending on the respective acoustic impedance. As tabulated over here, tissue mediums may have unique acoustic impedance depending on the density as well as the speed of the sound traveling through it. So basically, the ultrasound transducers, they are made of certain crystals that tend to contract and expand, or basically vibrates at its own resonant frequency whenever a voltage spike is applied to it. So this will then produce short bursts of about 2 to 3 cycles of pressure disturbances, which produce as the sound waves by damping the piezoelectric crystals. So this is known as the piezoelectric effect, which forms the basis of the generation of an ultrasound wave. The probe then switches to the receive mode to pick up the sound waves that are reflected back from the tissue to it, which forms some sort of like an echo. So bear in mind that only ultrasound waves that are reflected back from the tissues of the probe can form part of the image. So this is the pulse echo principle, which forms the basis of the generation of an ultrasound image. So apart from being reflected, some of the ultrasound waves as they travel through the tissue medium may be attenuated either by refraction, thermal absorption, or scattering. So reflection is the reflectivity will be generally increased if the difference in the acoustic impedance between two tissue mediums are greater. Reflectivity is said to be greatest when the tissue or the object to be visualized lies perpendicularly to the axis of the ultrasound beam. Apart from that, some of the ultrasound waves that are not reflected may be refracted instead, and this can be seen in almost any tissue medium, but is more commonly seen especially in fatty tissue or when the transducer probe is being angled. So this will cause poor visualization of the object being visualized. At the same time, some of the ultrasound waves as they travel through the tissue may be absorbed as heat. So this is called as thermal absorption. So those high frequency waves, as they travel through the tissues, more of this wave will be absorbed compared to the lower frequency one. So that is why we often adopt the lower frequency transducer probe for better penetration or gradual visualization of the deeper structures. Some of the tissue structures which are very much smaller than the ultrasound waves, less than 0.1 millimeters, for example, may sometimes be seen scattered and produce a speckled appearance on the ultrasound image. So this is known as radiate scattering, but they do not form part of the true image actually. So when we discuss about ultrasound image capturing, there are a few determinants to be considered. First, of course, will be the ultrasound machine itself, the choice of the transducer probe, and the scanning techniques. So under scanning techniques, this is one thing that we should know. Sometimes we may need to move or manipulate the transducer probe to produce a perpendicular axis of the object being visualized to the axis of the ultrasound beam to capture a good ultrasound image. So some of the cardinal movements will include sliding, tilting or fanning, rotating, as well as rocking. So let's spare a few seconds to watch a short video on this cardinal movement. First, we have sliding, which is basically the motion along the long axis across the body tissues, either to the left or to the right, or up and down, without changing the angle of inclination and keep it at 90 degrees. Next, we have fanning or tilting, which is the motion around the short axis across a fixed part of the body, but keeping away the angle of inclination from 90. Rotating is rotating in either the counterclockwise or clockwise rotation. Rocking is a rotation along the long axis, keeping it at 90 degrees. And compression is for us to visualize, for example, vessels. Okay. So going into the detail, basically sliding will help us to find a better and usually the best imaging window, and it allows us to move to different areas of the body or to trace a specific structure like a blood vessel. Tilting or fanning is moving the transducer from side to side along the short axis of the probe. At the same time, it will also alter the angle of inclination away from 90 degrees. So this will allow us to visualize multiple cross-sectional images of a structure. Rotating means turning the transducer either in the clockwise or counterclockwise direction. And this is most commonly used to switch between the long and the short axis of a specific structure. Rocking the ultrasound probe either towards or away from the probe indicator along the long axis is often done to help to center us to the area of interest. And by this way, the image is kept in plane throughout the manipulation. Next, I'll move on to the modes of imaging. So this is some extra knowledge to know. So there are a few modes of imaging that we can know. First will be the conventional imaging. So this is generated by a single linear array from a primary frequency which is designated by the transducer itself. So each of the target is insulated at a fixed single constant angle. Then we have the compound imaging, which is generated by several overlapping frames, either from different angles, where we call it as a spatial compounding, or frequencies, where we call it as the frequency compounding. So this will help us to generate better delineated margins. It also helps to reduce the image artifacts and also the noise and also the speckle appearance and enhance image contrast. Next, we have the tissue harmonic imaging, where it combines information from harmonic frequencies which are generated by the ultrasound beam as it transmits through the tissue. Tissue harmonic imaging will help to improve tissue contrast by suppressing the scattering signals. And nowadays, most of the ultrasound manufacturers, they often incorporate or adopt THI as a default mode, as it has been shown to have better resolution images, improve tissue penetration, and enhance margin compared to the conventional sonography techniques. So this is a picture to show or compare the ultrasound image with the conventional and the compound imaging. As you can see over here, the radial nerve is better delineated here compared to the conventional one. So there are some basic function keys on the ultrasound machine that will help us to optimize an ultrasound image. This will include the frequency, transducer frequency, the depth, focus, gain, and Doppler. Going into detail each case, first we discuss about transducer frequency. Probe selection is also an important determinant in helping us to capture as well as optimize an ultrasound image. So there are a few factors to consider when we choose transducer probe. So this includes resolution, penetration, as well as the size of the transducer footprint. So different frequency has different effect on the penetration as well as the image resolution. So transducer frequency basically determines the Asia resolution. The general rule is to choose the highest frequency available for the transducer probe range. The best frequency is then adjusted within each transducer range according to the depth of the nerve. However, as the ultrasound waves travel through the tissue medium, some of it may be thermally absorbed or attenuated. And the higher the ultrasound frequency, the more rapid will be the absorption. So the less distance sound propagation there will be. So the general rule is to use lower frequency transducer to scan deeper structures, and high-frequency transducer for superficial structures. So this is a picture to show the different ultrasound transducer probes available. We have the linear probe, curvilinear probe over here, and the so-called echo probe, the phase array probe actually. So these are the footprints or the size of the footprints of the transducer. So this table shows us or guide us in the probe selection. As you can see here, high frequency linear probe are often used for superficial blocks, whereas the deeper probes can be used to assess deeper structures. Lower frequency. Examples of images with different transducer frequencies. This one is the high frequency, this one is the lower frequency. So next will be the depth. So depth controls increase or decrease the image field by predetermining depth increments. By increasing the depth, the image resolution will decrease. So the depth at which the peripheral nerves and also the facial plane are located will depend on the patient's build as well as the width of the overlying subcutaneous tissues. Whenever possible, we should try to locate the target nerve of the facial plane in the center of the ultrasound screen to obtain the best image resolution. So this is a table showing the suggested optimal imaging depth and frequency for some of the common facial plane and PMBs. Next will be focus. So the width of the ultrasound beam will determine the lateral resolution. The focus is adjusted at the level of the target nerve, and the best image quality for the nerve will be obtained by choosing an appropriate frequency transducer as well as the focal zone, where the lateral resolution will be maximal and the beam width will be at its narrowest. The spatial resolution can then be enhanced by choosing a higher frequency transducer and focusing the ultrasound beam at the focal zone. Selecting not more than 2 focal zones can yield better image quality than multiple focal zones, as the latter will decrease the frame refreshment rate and hence the temporal resolution. Next will be the gain, which is simply defined as the amplification of the ultrasound signal which returns to the transducer after reflection from the tissues at varying depths. So on the images, these signals, they are present with white or we call the bright dots on the screen, and they can be adjusted as overall gain or time gain compensation at desired depth. So this will help to compensate for the loss of the signals as they are reflected from and they travel back through the tissues. So for peripheral nerve imaging, the optimal gain is typically the gain at which the best contrast is obtained between the nerves and the adjacent muscles and connective tissues. Excessive or inadequate gain will cause blurring of the tissue boundaries and loss of image contrast. So this is a picture to compare the different gain adjustments, overall gain adjustment. There's not enough, just nice, or if there's too much. And this again, on the other hand, is for time gain compensation adjustment. This is just nice, this is just, sorry, this is not enough. Next will be the Doppler. So this is used to detect vascular structures in the vicinity of the targeted nerve and along the needle path. So it also helps to detect the location of the spread of the local anesthetic injection. Doppler velocity is said to be best set between 15 and 35 centimeters per second to help reduce the aliasing of the color Doppler imaging and the artifacts of the color. So one rule of color Doppler will be demonic bar, where it stands for blue away and red towards. So sometimes people will say, as you get closer to someone, you tend to blush because you are shy, so you turn red. So that's how we remember. So you can adjust the gate to limit the size of the sample volume in the axial direction. For greater sensitivity, the sample volume should be small to overlay only the area of interest. Note that by applying excessive pressure to the transducer during imaging, this may collapse the small and medium-sized vessels, which less elastic tissue and will prevent their detection with Doppler. These are examples of the Doppler imaging of the small median artery. This is with high flow color Doppler, and this is with low flow color Doppler, and this is with power Doppler. So moving on to the next part, ultrasound artifacts. So they are basically any image aberration that does not represent the true anatomic structures and is important for us to pick up for optimal image capture. So first we have the contact artifact, which results from the contact problem between the probe and the skin. So for a good ultrasound image, there should have some kind of acoustic coupling. So this may present as shadowing or lack of the image appearing from the top of the image. So this can occur either due to, for example, lack of the acoustic couples, like a gel, or problem with the transducer or the skin surface. Next, we have anisotropy, which is seen as a change of the echogenicity of the tissue at different angles of insonation. This is a property of some fibrillar tissues, for example, nerves and tendons, that will reflect most of the ultrasound waves in the same direction. So, for example, with this, echogenicity is reduced as it travels. Next, we have acoustic shadowing. This is when the ultrasound signals are attenuated by the structures that either absorb, impede, or reflect the energy, for example, by hard structures, bone, calcifications, or even by air. So this will result in a poor image visualization, absent echo image, and will often appear as a shadow below a bright hyperechoic interface. This, however, will help facilitate the diagnosis of calcifications, for example, gallstones or scar tissues, and they may also be used to identify bony landmarks, but may interfere with the nerve visualization. So to overcome this ultrasound artifact, we can change the scanning angle, alignment, or imaging plane. So this is an example of the acoustic shadow. This is deep to the bone, rib, and this is deep to calcifications, shadowing under the hypoid structure. Next, we have the acoustic enhancement, which is also known as the post-cystic enhancements. They often manifest as an increase in echogenicity deep to a structure that transmits the sound better than the surrounding soft tissues. And it usually occurs when the echo signals are over-amplified disproportionately to other echo signals at the same depth. So to overcome this, we can either change the angle or plane of the imaging or correct the time gain compensation. So a picture showing the posterior enhancement. Over here, below the subclavian artery, and also here, below the femoral artery. So may I obscure the femoral nerve visualization over here. Next, we have the reverberation. This may occur between two highly reflective parallel interfaces or between the transducer and a strong reflector in parallel. So what we can often see is parallel equally spaced multiple bright linear echoes that decrease in intensity with an increase in depth, which is deeper to the strong reflector. So because they take a longer time to return back to the transducer, they may appear to occur along an increasing depth. So to overcome this, we can slightly alter the scanning direction or decrease the ultrasound frequency. Next, we have reflection artifacts or a mirror image. This often results from a highly reflective linear boundary that acts like a mirror itself. So the structure located on one side of the interface often repeats on the other side like a mirror at an equal distance. So the transducer receives both direct echoes from the object as well as indirect echoes from the mirror. The duplicated artifactual image will be less bright and deeper than the real image because indirect echoes transmit a longer distance and their energy is attenuated or weakened in that way. So to overcome this, can consider changing the scanning direction. Next, we have the refraction artifacts, which looks somehow like a bayonet. So ultrasound beam, they can be bent by reflection at large interfaces with different speeds of sound on either side on the soft tissue. So this is commonly seen like a band, as you can see in this picture. here. So as it passes through two tissues with different acoustic impedance. Next, we have the propagation velocity error, which is seen as a displacement or discontinuity of an interface, which is caused by the difference of the actual velocity of the ultrasound propagation in soft tissue compared with the calibrated speed, which is assumed to be on an average constant velocity of 1,540 meters per second. So the reflector is erroneously displaced on the image closer to the transducer by an error in distance calculations. Then we have slight thickness artifacts, where there is presence of echoes within the image that arise from structures outside the image plane. This is most noticeable when viewing targets like blood vessels in longitudinal section, when echoes arising from the steeply curved vessel surface outside the image plane show up as echoes within the vessel lumen itself. So it appears, for example, like it's from within the vessel lumen itself. So there are some points that we need to take note when we have to prepare ourselves to scan a structure. So this can often be remembered by the mnemonic of scanning, which stands for supplies. We have to ensure there's adequate equipment, sources, supplies, comfortable positioning of the patient, the correct ambience, identify the patient and the procedure to be done correctly, transducer, nominate transducer, and this procedure should be performed under aseptic techniques. Infection control needs to be taken care of. And we should always take note of the lateral and medial side of the screen, identify before we attempt any needle puncture, and consider attain the optimal ultrasound image by the 5 functional keys as mentioned earlier. So these are the 2 basic needle insertion techniques that usually adopted: in-plane and out-of-plane techniques. So for in-plane technique, the needle is placed in the plane of the ultrasound beam. So the best course will be to bring the needle in plane is by sliding. Whereas for the out-of-plane technique, the needle is inserted perpendicularly or at an oblique angle to the transducer. However, this is often more difficult to perform and requires a higher degree of skill to visualize the needle tip. So this is a table to compare the in-plane and out-of-plane techniques and their respective pros and cons. So for in-plane technique, it allows the full visualization of the needle shaft and the tip, and it has good visibility of the nerve needle interface. But this is difficult to perform, and it requires a precise alignment of the ultrasound beam. Out-of-plane technique is a familiar needle insertion point and short skin to nerve distance. But it often requires higher degree of skill to visualize the needle tip clearly. So the needle is often only seen as the white spot as it passes through the ultrasound beam. So just to summarize everything together, back to the earlier part, modes of imaging, we have compound and conventional imaging. So compound imaging will offer better image resolution and margin enhancement, and also reduces the ultrasound artifacts compared to the conventional sonography technique. So how to optimize an ultrasound image? Like I mentioned earlier, consider of the 5 keys and how to adjust accordingly. These are my list of references. That's all from me. Thank you. Any question?
Any questions for Rachel? It's a bit of a dry theoretical topic. It is best to be seen in practice. But I think you need to understand the machine that you have. So for example, with our sonosite in OT, what I will usually do is that because a lot of our blocks are done in such a way where the needle is in the middle of the screen. So a lot of the time, if you look at the sono side, beside the power button, there's a button there that you can change the kind of view, whether it is resolution, general, or penetration. I have never tried to look into the manual, but based on my experience using experimenting with the button, I find that using the penetration mode is the best when it comes to visualizing at the middle to lower half of the screen, which I think is maybe because when you put it in the penetration mode, it probably puts it at a lower frequency, and therefore you have a bit better penetration for the deeper structures. Whereas if you change it to the resolution mode, then you find that, especially in the superficial part of the screen, then you have a quite very good resolution. You get good resolution, but you can't see much deep inside. That's my experience. So whenever I use the Sonosite, I will always change the mode in that sense. Of course, our Sonosite does not have a focus button. However, let's say if you use the Sonoscape, for example, for blocks involving the curvilinear probe, you find that particular machine does have a focus button. So the focus button is very useful because you are able to focus the beam at the desired depth, and you get good resolution at that particular depth. And therefore, that will aid you very much. In the ICU, our Acuson, the Acusons have the I think even the one in Dahlia hybrid, both of them have time gain compensation, so that can help. But I find that I do not turn it on whenever I want to do procedures, real ultrasound. If I want to scan and look at such structure, then I would turn it on. But usually I do not turn it on for procedures per se. So I think Richard can just go back to the anisotropy just now. So anisotropy is something you can actually see very clearly in your usual practice. So when because tissues have different speed, actual speed of sound wave speed of which the sound waves travel through. So as if you put the probe on a patient and you tilt it from one side to the other, so sometimes you would see that the color changes, and sometimes you see that the color changes in the opposite manner. So this is very useful, for example, when you do tap blocks. So one of the ways that you can help to differentiate where is the external oblique, internal oblique, and the trapezius abdominis muscles is that you can tilt the probe from side to side, and you will see that the colors shift of the three layers. And in this example, you will see where the median nerve is highlighted, you will find that as the tilting of the probe changes, suddenly you get the difference in the color per se of the image that is formed, and then it helps you to see the structure that you want to see. Any questions? Of course, in our when it comes to vascular access, of course, color can be useful, but most of the times we do not particularly use it. But let's say if you want to use it, for example, DVT scanning, then color Doppler can be useful. Not really to identify where is the vessel, but actually to see whether there's actual flow. So let's say if you diminish, if you put the probe at the vessel and then you tilt it so that you have the one, so you can actually get the directional flow of towards or away from the probe, and then you put on the color, then you can see whether the color fills up the whole lumen, or the color does not fill up the whole lumen, and there's an area within that is echogenic, which would be a thrombus. But of course, you can't tilt it too much because like in the earlier slides, so if you tilt it too much, then the reflected ultrasound wave will travel away from the structure, and then the original image becomes impaired in the first place. So that's why it is very important in your orientation scanning from the first talk by Malik and orientation versus block scan. So when you want to do your orientation scan, it's very important that you try to adjust the probe so that you get the best image of the structure before you decide on when to and where to do your needling phase. Okay, any comments, questions?
Tami, I have a question. How do we improve our needle visualization when performing deeper blocks such as interior sciatic, for example?
I think the key is knowing what you can do with the equipment that you have. For example, if you are, I know that we have never done anterior sciatic, but if we are able, but for example, like real-time ultrasound guided spinals, you know that the curvilinear probe is curved, but the needle goes in a straight direction. So actually, the needle itself is actually more or less not as well visualized because of the nature of the intonation. But in that case, you depend a lot on your tissue movement. So that's why macam for deep blocks where the needle is not necessarily perpendicular to the beam, then you have no choice but to depend on tissue movement to decide on where is the needle. Because you can have the most expensive needle in the world, but it's not gonna reflect enough of the ultrasound beam towards the ultrasound probe. But if let's say you are doing a procedure with a linear probe and it's a superficial structure, then you know that you can ideally see the needle. And of course, the most important thing is to keep the needle in a relatively flat trajectory. So the more acute the angle, then the lesser amount of the needle visualization because of physics of the ultrasound reflection. Of course, this is partially mitigated by use of so-called block needles, which have good echogenicity, but it will never be as good as an ideal good technique where the needle is more or less parallel with the probe. So that's why, for example, like blocks with like the popliteal sciatic. So that is very important that you try to gauge where is the depth of the sciatic nerve, and then you insert your needle perpendicular to the probe. So that when the needle goes into the tissue space, it is very seen as a very bright white line because it's an ideal depth and direction. So in that kind of scenario, there is no excuse. You must see the needle. There's no, if you cannot see the needle, it is more or less not acceptable needling technique. As compared to, let's say, if you do an anterior sciatic, or let's say if you do an ultrasound guided spinal, you know that more or less you are going to depend more on tissue movement versus the needle itself. But of course, if you want to have a flat trajectory, you have to accept that sometimes you have to insert your needle a bit further away from the probe. So that means you must have good 3D visualization of having a steady hand at the structure, and then you have to distance yourself away and get the entry point at an ideal length, and then so that the needle is relatively flat. This is very easy for some blocks like the femoral nerve, but it can be very difficult for some blocks like the ceratopectoral, because in the ceratopectoral, the probe is actually slanted on the chest wall and it's not exactly vertical. Because if you put it vertical, you won't see the rib. So you have to put it slanted. But if you put it slanted, then you know you need to adjust your needle so that it remains in the beam when the needle actually passes towards the rib. Okay, if not, we'd like to thank Rachel for her presentation.
Thank you. Thank you everyone for listening.